Okay, let's unpack this. Have you ever wondered why some people facing incredibly difficult situations seem to bounce back quickly, while others are profoundly impacted right away?
Yeah, it's striking, isn't it? Life throws devastating curveballs.
Exactly. And sometimes that reaction is immediate, intense, hitting you hard within days or weeks, not, months or years down the line.
That immediate impact is fascinating and really important to understand. It's not just a fleeting feeling of shock. It can be a complex, distinct psychological response that needs specific attention.
Which is exactly why today we're doing a deep dive into acute stress disorder, often called ASD.
Right.
We're using your revision notes on this topic as our guide, sort of cutting through the density to find the absolute must-know points. Our mission, to make this information stick, giving you that high-yield understanding for revision or just getting a handle on this crucial topic.
Absolutely. We'll walk through it together step by step, covering everything from, well, what it is, how the body and mind react, who might be more vulnerable,
How it's recognized, managed.
how it's managed, and what the potential outcomes are. Think of this as your essential shortcut to understanding ASD.
All right, let's jump right in then. The core definition. What exactly is acute stress disorder?
Okay. At its heart, it's a psychological disorder, but crucially, it arises directly in response to experiencing or witnessing a traumatic event.
So the trauma is the absolute starting point.
It's the non-negotiable starting point, yes.
And the notes make it absolutely clear that timing is everything here, right?
It really is. It's probably the single most critical defining characteristic for ASD compared to other trauma responses. The distressing symptoms must develop within 1 month of that traumatic experience.
Within a month, okay?
That 30-day window is key for the diagnosis.
So for anyone using this for revision, here's your memory tip. ASD is the acute reaction diagnosed within 4 weeks.
Right.
Post-traumatic stress disorder, or PTSD, that's the chronic reaction, diagnosed after 4 weeks.
Exactly. That 4-week mark is your diagnostic dividing line. It's crucial.
Got it.
And, the notes mention this immediate reaction has been called various things. Over time, you might see terms like acute crisis reaction, acute reaction to stress,
Oh, right.
or even older, maybe less formal terms like shock, psychic shock, or battle fatigue. They all kind of describe that intense early response to trauma.
So we know what it is and when it happens. That leads naturally to the question, why? What actually triggers this specific disorder in some people after a trauma? The etiology.
Well, like we said, exposure to a traumatic event is the prerequisite. The notes give classic examples. Yeah. Serious accidents, natural disasters, being assaulted.
Or even seeing something happen to someone else.
Yes. Or even witnessing someone else's trauma. That counts.
But it's not just the event itself, is it? Because not everyone exposed gets ASD. The notes describe it as multifactorial.
Absolutely, and that's key. This isn't a simple one-to-one cause and effect. The source material emphasizes it's a complex interplay. Yes, the trauma is necessary, but whether someone develops ASD is influenced by a mix of things. Genetic predisposition, biological responses, psychological factors, and their environmental context, like their support network. It's a layered picture.
Right, which brings us to the risk factors. This is where it gets really interesting. If the event isn't the only factor, what makes some individuals more susceptible? Who is at higher risk?
Great question. The material highlights several vulnerabilities. A personal or family history of psychiatric issues is a significant one.
Okay, so previous mental health stuff.
Yes, and having gone through previous traumatic experiences, especially during childhood, that also increases risk.
And external factors. You mentioned support systems.
Yeah, a lack of strong social support is noted as a risk factor. And certain pre-existing personality traits can potentially make someone more vulnerable to developing ASD after trauma.
The notes also really stress the importance of how the event is perceived, don't they?
Crucially, it's not solely about the objective severity of the event, though that matters, of course, but it's often how it's subjectively perceived, particularly if it felt life-threatening.
Even if it wasn't actually lethal.
Exactly. Even non-lethal situations can be profoundly traumatic to that individual. The personal meaning attached to the event is vital.
Okay. For memory, let's just quickly reinforce those high-impact event examples. The notes mention serious accidents, natural disasters, combat, torture, assaults, terrorist incidents.
And importantly, witnessing sudden or violent injury or death, including loved ones, and ongoing trauma like domestic violence, is also listed. It's a broad range.
Yeah.
And because of their jobs or circumstances, certain groups just have inherently higher exposure, putting them at elevated risk.
Right. The notes call out specific groups.
They do. Road casualties, both the injured people and witnesses, refugees and asylum seekers, first responders, police, ambulance crews, firefighters, and military personnel. These are populations where, sadly, ASD is more common.
So we have the event, and we have these risk factors. What's actually happening inside the body? Let's talk biology, the pathophysiology.
Okay, so this is basically about the body's fundamental stress response system going into overdrive.
All right.
Or not regulating properly.
Kind of gets stuck.
In a way, yes. The notes specifically pinpoint dysregulation of the hypothalamic pituitary adrenal axis, the HPA axis.
Right, that central communication pathway.
Exactly. Between the brain and adrenal glands that manages our response to stress. It's not working as it should.
And are there changes in the brain itself associated with this?
Yes. The source material indicates alterations in key brain areas involved in processing and regulating emotions. It specifically highlights the amygdala.
The fear center?
Heavily involved in fear and threat detection, yes. And the prefrontal cortex, which would help modulate that fear response, kind of put the brakes on. In ASD, this system isn't functioning optimally.
Okay. So when someone presents with symptoms after trauma, how does a clinician distinguish ASD from other conditions? What else might it look like? The differential diagnosis.
Right. This is crucial. You absolutely need to distinguish ASD from its closest relative, PTSD. And remembering that critical 1-month time difference we talked about is your primary tool here.
Within a month,
Yeah.
ASD. After a month, PTSD.
That's the core distinction. You also need to differentiate it from adjustment disorder. That's a reaction to a stressor. But it doesn't necessarily involve the intense specific symptoms like dissociation or re-experiencing that are required for ASD.
What about other common mental health conditions? Can they look similar?
They can, yeah. The notes list several because their symptoms can overlap, particularly the anxiety and mood features. You need to consider things like generalized anxiety disorder, social anxiety disorder, panic disorder,
OCR.
obsessive compulsive disorder, yes. And depression is a very common co-occurring feature, or it can present acutely after trauma.
The list in the notes goes on a bit.
It does. You'd also consider conditions like schizophrenia, as severe anxiety can sometimes precede psychosis, though that's less common. Dementia can also be associated with increased anxiety and depression.
And substance use.
And importantly, yes, alcohol misuse is often present in people experiencing trauma responses. Plus, withdrawal symptoms can sometimes mimic anxiety or agitation. So a really thorough assessment is vital to rule these other things out or identify them if they coexist.
Shifting gears slightly, how common is ASD? Do we have specific numbers? What's the epidemiology look like?
Well, the notes mentioned that specific UK prevalence data for ASD itself is actually quite limited.
Oh, okay.
However, drawing on broader data, the global estimate provided is that roughly 5% to 20% of individuals who are exposed to a qualifying traumatic event may go on to develop acute stress disorder.
So definitely not everyone, but still a significant minority.
A significant minority, yes.
All right, let's get into the practical side. What does ASD actually look like in a person? What are the clinical features or symptoms you'd observe?
Okay. The notes break these down clearly, and remember, they all appear after the traumatic event. There are 7 key symptom categories outlined.
7 types. Okay, walk us through them.
First, intrusive thoughts and memories. This is where the trauma keeps forcing its way back into consciousness.
How?
Through distressing recurring thoughts, vivid flashbacks like reliving the event, or nightmares specifically about the trauma.
So not just general bad dreams, but trauma-specific ones.
Exactly. Then there's dissociation, which is a sense of being disconnected from reality.
What does that feel like?
The notes even give the striking example of feeling like time is slowing down or being in a daze.
Okay, next.
Negative mood. This covers a whole range of mood changes following the event, things like persistent sadness, anxiety, anger, guilt, or even self-blame related to the trauma or its aftermath.
And people often try to avoid things that remind them, right?
Absolutely, that's avoidance. This involves active efforts to steer clear of reminders of the trauma. Could be avoiding places, people, activities, or even just conversations about the event.
What about feeling constantly on edge, jumpy?
That's the arousal symptoms. This is a state of heightened alertness, feeling constantly hypervigilant, like danger is still present. It often comes with significant sleep disturbances, trouble falling asleep, staying asleep, restless sleep.
The notes mention a second type of dissociative symptom.
Yes, specific dissociative symptoms involving personal detachment. This is feeling detached from oneself. It's called depersonalization, like you're observing yourself from outside.
Wow.
Or feeling detached from one's surroundings, derealization, where the world feels unreal or dreamlike. It's a profound sense of unreality.
And finally, physical reactions.
Those are the autonomic signs of anxiety. Basically, the physical signs of the body's stress response kicking in like a rapid heartbeat, sweating, trembling, shortness of breath, feeling faint.
So you see a combination of these 7 symptom types intrusions: dissociation from reality, negative mood, avoidance, high arousal, personal detachment, and physical anxiety signs, all starting within 1 month of a trauma. That seems to be the clinical picture of ASD, according to the notes.
That's it, exactly. And again, that 1-month time frame is crucial. If these symptoms hang around longer than that, the diagnosis may shift to PTSD.
Given these varied symptoms, how do clinicians actually figure out if it's ASD and not something else? What investigations are done?
The notes are very clear and quite direct here. There are no specific diagnostic tests for acute stress disorder.
No scans, no blood tests, nothing like that.
None mentioned as diagnostic tools for ASD itself. The diagnosis relies entirely on a comprehensive clinical assessment.
So, talking to the patient.
Yes, it means a detailed interview, getting a thorough history of the traumatic event, and a careful evaluation of the patient's specific symptoms against the diagnostic criteria we just discussed. It's ultimately a clinical judgment based on the patient's report and how they present.
Okay. Once it's diagnosed, how is ASD managed? What are the recommended treatment approaches according to the notes?
Right, management. The source material covers both psychological interventions and the cautious use of medication.
Let's look at the psychological side first. What's recommended?
The notes recommend trauma-focused cognitive behavioral therapy, or TFCBT, as the first-line treatment, especially if the person has significant impairment in their daily life because of the symptoms.
What does TFCBT involve?
It uses techniques like exposure treatment, helping the person gradually and safely confront trauma-related memories or situations they've been avoiding. And it also involves challenging negative thoughts and beliefs that developed after the event.
And EMDR is mentioned too, eye movement desensitization and reprocessing. How does that fit in?
Yes, EMDR. The notes describe it as an integrative psychotherapy. It uses standardized protocols, often involving guided eye movements or other forms of bilateral stimulation,
Right.
with the goal of helping the brain process unprocessed traumatic memories so they become less distressing. It definitely requires a specifically trained therapist.
Is it as strongly recommended as CBT?
Well, the notes say the WHO recommends EMDR in specific cases for trauma. However, for acute stress specifically, the source notes state that the evidence supporting its widespread recommendation is maybe less robust compared to trauma-focused CBT. So TFCBT seems to be the primary go-to.
Okay. How about medication? The notes seemed quite cautious here, particularly about certain types.
Yes. Particularly regarding benzodiazepines, drugs like diazepam or lorazepam. The notes state they can be used, but very cautiously, maybe for severe acute symptoms like extreme agitation or complete inability to sleep.
That there's a big warning.
A major caution, yes, due to their high potential for addiction and dependence. And critically, the notes highlight WHO advice, which is against the routine use of benzodiazepines for acute traumatic stress symptoms. So really a last resort, short term, if at all.
So what can be used for related symptoms like trouble sleeping?
For insomnia, the focus should be on non-medication approaches first. Things like relaxation techniques and focusing on good sleep hygiene are recommended. The notes specifically advise avoiding using hypnotics or sleeping pills for this.
And for those physical symptoms of anxiety, we mentioned the racing heart, the sweating.
For those, beta blockers are listed as something that can help. They can relieve the physical symptoms of acute stress.
What's the advantage there?
The notes point out they are non-addictive and generally don't cause drowsiness, which makes them suitable for use on an as-needed basis just to manage those physical feelings when they spike.
It's also worth remembering that sometimes this just gets better on its own, right? Without formal treatment.
That's a really important point the notes make. Mild symptoms may resolve spontaneously, sometimes within hours or days. Nature takes its course.
But not always.
Not always. If symptoms are severe or prolonged, intervention is definitely needed. And interestingly, the notes also mention there's limited evidence supporting the effectiveness of just simple problem-solving counseling or general psychoeducation alone for significant ASD symptoms. You usually need something more targeted, like TFCBT.
Okay, so summarizing the management recommendations from the source. Trauma-focused CBT is the main recommendation for significant symptoms. EMDR has a potential role, maybe, but with less evidence for acute stress specifically. Use benzos very cautiously, sparingly, if at all. WHO advises against them. And beta blockers can target physical symptoms as needed.
That captures the key treatment points from the material pretty well, yes.
Moving towards the prognosis. What's the likely path for someone diagnosed with ASD? Does it always turn into PTSD?
Okay, prognosis. It varies, of course, but there's definitely positive news here. Many individuals diagnosed with ASD do recover fully, often within weeks or months, and crucially, without going on to develop chronic PTSD.
Does getting help early make a difference to that outcome?
Absolutely. The notes state that early intervention and having good support are associated with improved outcomes. It helps recovery.
And how long do the symptoms typically last if it is just ASD?
For most people who meet the ASD criteria, the symptoms are indeed relatively short-lived, lasting not more than 1 month, by definition, really.
But does receiving an ASD diagnosis mean you're definitely going to develop PTSD later? Is it a guarantee?
That's a common question, and no, it's not a guarantee.
Yeah.
The DSM-5 diagnosis of acute stress disorder is considered a predictor. It increases the risk of future PTSD development. However, the notes add a crucial detail. It has low sensitivity as a predictor, meaning many people who get an ASD diagnosis do not go on to develop PTSD. So while it flags a risk, it's far from certain. The notes also interestingly differentiate acute stress reaction, which is maybe a broader term, from the specific diagnosis of acute stress disorder, noting an unclear link between that more general reaction and long-term chronic problems.
Okay. Finally, what if ASD isn't treated? What are the potential complications? What are the risks of letting it go unaddressed?
Well, the most significant risk, and the one the notes really emphasize, is that untreated ASD significantly raises the likelihood of developing chronic post-traumatic stress disorder. That's the big one.
And beyond just the PTSD diagnosis itself?
Yes, it can have wider detrimental impacts. It can really affect a person's daily life. Their ability to work, their relationships, their overall quality of life can suffer significantly.
And other mental health problems.
Yes. The notes also highlight that untreated ASD increases vulnerability to developing other mental health issues down the line, particularly things like depression and substance use disorders, which might start as a way of coping.
Looking at all this material together, it's quite something. What's fascinating here, I think, is that subtle yet crucial distinction between a natural, intense, and very difficult reaction to trauma, which many people experience and recover from spontaneously, and a defined clinical disorder like ASD.
That's a great point. And considering how subjective the perception of trauma can be, as the notes highlighted, and that so many do recover naturally, how do we, as clinicians, or just as a supportive community, best navigate that immediate aftermath? How do we offer effective support while balancing, watchful waiting with timely, appropriate intervention for those who truly need it? It's a constant question in trauma care.
It really makes you think about the nuances of trauma recovery, doesn't it? Well, we've taken a deep dive into acute stress disorder today, pulling out the absolute key points straight from the revision notes.
Yep, covered everything from its definition and that crucial time frame.
To the causes, risk factors, what's happening biologically, the symptoms.
How it's diagnosed, or rather not diagnosed with, tests, the recommended management approaches.
And the typical outcome and the potential complications of not addressing it.
Hopefully, structuring this information like this and highlighting those crucial details and differences makes it much clearer and easier to recall, whether you're revising for exams or just wanting a solid understanding of this important topic.
Definitely. And if you are finding this kind of structured, high-yield deep dive helpful for your revision, remember you can find more resources to help you prepare over at passthemsre.com and freemsre.com.